Yes, I can hear you. Can you hear me?
Yes. How are you?
Okay. So first, thank you for the invitation. I've been watching the course, this session of the course, and it was really amazing. So congratulations for the organization.
Thank you so
I,
much.
I really had 20 minutes, and now I still have 12, and we are running late. So I'm gonna be a little bit faster. I usually talk fast, so I hope everyone can understand. So we're gonna talk about EVT for very massive defects. So I'm gonna focus in some things that I judge is most important. So first thing to know is why EVT is the best. EVT is the best for very massive defects because EVT can treat perforation, leaks, and fistulas. Doesn't matter the time if it's acute or chronic. The location, of course, you need just to place the device there, and the size of the defect. So EVT works for almost everything. So you need to know if it is a contained or uncontained collection, and if it's drained or undrained. So these are the most important things. And why EVT is so good? EVT is so good because our body does secretes a lot of fluids. So EVT provides aspiration, is the only technique to do that. Bacterial clearance and exudate control. It provides micro and macro deformation and also changes in perfusion, and thus improves healing. So first there is some pivotal principle. So you need to active negative pressure. This is a patient that removed the external drain in the thorax. So see, I am placing some water and the aspiration is very low. Then I close one orifice, you get more aspiration. When I don't close, we don't have aspiration. When I close both orifices, we have a very high flow. So this is because we are active negative pressure. So if it does not active negative pressure, it won't work. So make sure you understand that. We can place the EVT intraluminal, intracavitary, or both intraluminal and intracavitary, which I like to do in anastomotic dehiscence and for large associated collections. So when you have a collection with a drain. So this is a colorectal anastomosis. You see the leak. We have a contained collection with an external drain. So how to treat that? You need to remove the external drain. If you don't remove, you do not active negative pressure. So remove the external drain and place the drain internally. And then you're going to see the result. I only don't remove the external drain if I have an undrained collection. If I have an uncontained collection, so see here, there is no collection, it's just the abdominal cavity, a lot of infection. So I keep the external drain, but I kept the external drain. Then I do the EVT with the cap external drain, and every 12 hours I can use the drain to clean the cavity inside. It allows, it improves the healing. And this was the final result. And if you do not see the drain, check in the external drain, and then you're gonna find where is the defect. So these are some tips. So this is for contained perforation with undrained collections. These are the piece of cake for us. So you have the collection, there is no external drain, just place the EVT inside and you're gonna get the result. There is several types of EVT. I'm not gonna lose time here. So you have the normal polyurethane sponge, which more challenging to place. There is the need for multiple exchange and prolonged procedures because it's challenging. And then the LOSC starts to use the open pore film drain, which is easy placement, lower procedure time, and lower interval between exchange. And after that, we published the homemade endoscopic vacuum therapy, which is similar to the open pore film drain, but is cost effective. And here I'm gonna run a little bit. But this is the way we do the EVT. So you have, this is for belt. So we make a lot of rolls. Then we can use the sponge or the gauze with the antibacterial incised drain. And then after all the fenestrations, you do some suturing to avoid migration. So when you do the sponge, it's very important to do a transfixed suturing, okay, with nylon. Otherwise, sometimes it's hard to remove. We also like to use the triluminal tube. When you're going to place the EVT intraluminal, you can use the triluminal tube. Here are some homemade EVTs. Why I like to show this slide? Because there is no one which is better than the other. So in each case, you're going to use one EVT. For example, here, when we use close to the rectum, to the anus, we use this plug to avoid migration. We like to use for rectal. Sometimes you can use the one with accessory tube to wash. So there is a lot of types of EVTs that you can do. So be creative. There is other EVT device with the stand of the stand and the fact stand. I don't have experience, to be honest, but what I think, it's a very high cost, and you need to do multiple exchange, and this is going to be very challenging. So EVT is better than the stand. So why use both together if EVT is better already? So this, you need more data to make sure what I'm saying. So this was our data from 2002. We have 144 patients, and our clinical success after active negative pressure was 95%, which is very high. But make sure you active negative pressure. See, when we use in cases that negative pressure was not active, our rate of success went down to 89%. So make sure you active negative pressure. We did a sub-analysis, including esophageal, gastric, small bowel, colorectal, and other defects. And what we show is the clinical success is very similar, doesn't matter where you are. In a multivariable and unvariable regression analysis, we show that when you use two EVTs, one intraluminal and one intracavitary, the results are better. But of course, you just can use that if you have a large contained collection and a dehiscence in the anastomosis. Otherwise, you don't need to use. So here I have a lot of cases. Unfortunately, we won't have time to show all for you. This was a one-year-old girl with an heterogenic perforation during peg tube placement. You see, we open all the esophagus, so there is nothing to do here. So we use the modified EVT and we treat this patient in only 1 week. This is an interesting case showing that we like to use a lot of tubes. So here you have the lumen, complete dehiscence of the gastrojejunal anastomosis. We have one collection to the left and one collection to the right. So we have two contained collections, and one complete dehiscence of the anastomosis. So our approach here, we use two tubes. One intraluminal tube with the trilumina, one in the right cavity, intracavitary, and one in the left cavity. This was the final appearance after several exchanges. This is a case that I like to show you because this is important. We need to understand that. We have here, with the scope, we put contrast. We had one collection, and we inject through the pigtail stents, and there was another collection. They were not communicated. So we need to communicate both to treat. So what we did is we put a guide wire here, we came with the micro knife, and then we did a perforation here and connected both collections. After connected both collections, we dilate the orifice in the esophagus and we dilate the orifice between the collections. Then we placed the EVT, as you can see here. We fix it in the skin, and every 3 days we did a traction of 3 centimeters every 3 days. And then we didn't need to do a lot of procedure in this patient. And then after we got just this, we placed the intraluminal EVT and we closed the defect, as you can see. For post-bariatric surgery, it works very well. So here you see a clinical success of 95%, and when active negative pressure, 97%. So it's really, really helpful. And have a look that we love to do adjunctive therapies, because sometimes you cannot use only the EVT. You need to do septotomy, you need to do dilation. So make sure you do all you can to solve the patient's problem. And here you have a meta-analysis showing it's a very high clinical success rate using EVT. For small bowel, these are two interesting cases. In this case, you're going to see in duodenum. For these giant duodenal ulcers, I am sure EVT is the best approach. Even when you have bleeding, I'm going to show you later. But EVT is the best approach for this situation. And this is a very interesting case. We didn't publish it, but I always like to show in talks. These patients had two leaks. One very far from us. So the patient was in peritoneostomy. The surgeon helped me to place the EVT. So we placed one EVT down and we placed the triluminal tube here. And with that, this patient closed the peritoneostomy in 2 weeks, and in 4 weeks, she's having a normal life. And now she sent this picture recently. She is also married now. So the patient is alive again after this therapy. And this is another case that it's very interesting to show this patient. And we published this. The patient did 3 surgery. We have this and never closed it, even with EVT. And then we had an idea to do a magnetic anastomosis. So we placed one magnet in the collection and one magnet in the lumen. And here is the result. You can see an anastomosis of the collection to the lumen. And here you're going to see a big septum separating both. This big septum, we cut the septum with APC. And after cut the septum, you can see we created one compartment. And then we placed the EVT, and this is the result. So this is another colorectal case. This is also interesting. You see the collection, you see the external drain. So what do? I remove the external drain. Always, I place a guide wire before to make easier my EVT placement. So one hand I have traction, and with the second hand I had traction and control traction. Then I place the EVT inside the cavity, and after I have granulation tissue, you're gonna see granulation tissue. I do the septotomy, a very, very big septotomy. It's important to create one compartment. When you create one compartment, it's treated. So you can send the patient home after that. I always keep the EVT for 3 days just to a better healing, but this patient is okay. And then we also had some using EVT for liver. This is a liver abscess that we use the EVT through the skin. We can do this for liver, not for other GI organs, of course. And we also use the EVT for pancreatic necrosis. We are having some cases. It's very interesting. When you have pancreatic necrosis, it makes much easier the necrosectomy later. So use the EVT. You're gonna organize the collection better, and then you do the necrosectomy. It's much easier. So I really like to do that. So novel indications, we are using EVT for post-radiation ulcers. This patient, she could reconstruct the transit after we treated this large ulcer. So she's now with a normal life. And this is a palliative scenario. This patient was dying. As you can see, she has a 26 centimeter tumor, and she couldn't go home. We did the treatment with EVT, and then you can see we also placed an occluder. And this patient got better. She went home and she died at home. Preempt EVT, I think this is the future. So I am very, very passionate with this technique. So when the surgeons do the anastomosis, they finish the surgery, you go there underwater, place a guider and place the EVT. It's very, very simple. Treat for 5 days. And before the patient go home, you remove the EVT and have a look with the endoscope. It's very, very good. If the patient had a leak, at least the EVT will keep the patient stable. And then you exchange the EVT for a therapeutic and not preemptive. And finally, we are using EVT for bleeding. As you guys know, when you have bleeding the duodenum, diffuse duodenal bleeding, we place the EVT. There is a reduction in the intraluminal pressure, change in perfusion, and the micro and macro deformation will promote healing. Here you can see the villus preserved after 5 days of this. These are the same patients. Then after that, we have more courage, and we start to use EVT for all kinds of bleeding with very interesting results. We recently submitted to endoscopy, and it's under review. And I think we're going to publish that because it's a very interesting technique. When you have diffuse bleeding, when you have large ulcers, when it's very inflamed, the local post-radiation, large ulcers, EVT is a very, very good option. And to finish my presentation, adverse events, of course, they can occur. So be careful when you are doing a procedure. You cannot use air. Otherwise, you're gonna have you can do a contained collection into a uncontained collection. You can rupture the wall, so be careful. When you do contrast, do under intubation. Here you can see the cuff saved the patient, the contrast here. And of course, as I said, you need to have the machine working well. If you have bubbles here, it's because it's not active negative pressure. So be careful, and be careful of the nose of the patients. So how to active negative pressure? Of course, you need to know what you are doing. You need to know the pathophysiology and the mechanism of action. And the most important, you have to have empathy with patient and family. It's very hard. These patients are very challenged, so you need to know how to talk to them. And of course, you need a multidisciplinary team. Endoscopy is just a part of the treatment. So I do recommend always send these patients to a center of excellence. And challenges, as I said, it's a very complex patient, time consuming, and no insurance cover in most of cases. So it's quite hard to use this technique in several scenarios. So my take-home message is EVT presents a high efficacy and adequate safety profile for the management of transmural GI defects. And due to its unique mechanism of action, EVT is very effective for the treatment of these defects. The homemade EVT will expand the use of EVT by providing less invasive treatment to more patients worldwide, especially in non-research settings. So please trust me, EVT is a very good option for those GI defects. Thank you.